Welcome back, everybody. I'm Mike, and Tom is with me, and we are back for the 8th part in our documentation series.
Gosh, it seems like only yesterday that we started this.
No, it's been longer than that.
I gotcha.
There's been a lot of work that's gone in behind the scenes. Luckily, you guys only have to see the final product, so
right.
That's nice.
And try to keep it a little shorter.
Yeah,
if we can.
Good luck with
we
that.
always tend to go longer. We wanted to keep these less than 5 minutes, and I think we're running anywhere from 8 to 12.
Yeah, so you can see how that turned out for
right.
us. Anyways, so this is geared predominantly towards new hires, physicians and MLPs, but certainly our more experienced physicians and MLPs, I think, could also learn some things from this, and so we're hopeful that you find this this helpful. So last module we talked about what we call the art of the chart, only including pertinent information, not repeating a lot of information in your documentation. Remember that the length of the chart should always reflect the complexity of the patient, and then once again, please beware of how you use templates.
Right. Just remember you're telling a story, and it needs to make sense to whoever's reading it.
So now we want to talk about some things that we see folks do sometimes that probably you shouldn't ever do when you're documenting.
I don't think there's any probably about it. These are all, I think, kind of absolutes.
Absolutes, yeah. So first of all is inconsistencies. So again, we've talked about this before, but it's such an important issue. I feel like we need to make special, take some time here to really make special comment about it. So where I see most of the inconsistencies coming is either with templates, and obviously you know how I feel about that, or with the nursing notes, especially the nurse's notes in triage. And what happens is, the physician picks up a chart, they look at the chief complaint, they go in and talk to the patient. Patient gives them the history but doesn't mention a key part of the history that they told the triage nurse that the triage nurse documented.
Right. Or they changed their story, or there was some misunderstanding about what exactly was going on, why they really came into the department. So it doesn't mean that your chart can't contradict somebody else's note. What it does mean is that if there is a contradiction, you have to explain it. So if a nurse says a baby's lethargic, and then your chart, ought to reflect that why the baby's not lethargic unless they really are, and what they actually look like. So could be that and you could even put it in there. Hey, the child was somewhat sleepy in triage, but currently cooing, playful, active, actively drinking their
good
bottle.
eye contact, eating all four. Yeah.
So you've got to be able to explain any inconsistencies there.
Yeah. Other things that we think are absolute, do not do them, is pejorative comments. You want to avoid those at all costs. And, 15 years ago, I think we probably saw more of this. We don't see as much of it now. It certainly can be tempting and sometimes can feel real good to, put in your chart what you actually think of the patient. But you've got to remember that in this day and age of electronic medical records, the patient or their relative or their lawyer or somebody, a friend, is going to see that chart at some point.
And they are not going to be happy.
Will not be happy if you refer to them as a douchebag.
Right. So, you want to have things, you can have, information in there that helps the reader understand what's going on. Patient is a difficult historian. Patient is clinically intoxicated. Patient is agitated, is cannot cooperate with the exam because of, severe pain, or because they're intoxicated, or whatever. I mean, you can put factual comments in there, but do not, avoid opinions or, insults.
Yeah, absolutely.
Even if they're appropriate.
And I can tell you, I've been asked, a couple times in my career as a director, people have done this. Patient or their relative sees it, and then I've got to deal with not only the complaint, but having to tell somebody they've got to go back and change their chart, which no one ever likes doing after the fact. So I would avoid this at all costs. Also, again, we see this sometimes when we have a particular difficult patient subspecialist relationship, or we have a subspecialist who maybe isn't comfortable with the patient's complaint. And sometimes you can get into what we call chart wars, where one provider documents one thing, the other provider documents the other, and then they go back and forth trying to explain why their documentation is actually the correct one. And sometimes these can get quite nasty. I would encourage you to avoid this at all costs. If if you and another physician are having a disagreement about how to manage a patient, that disagreement should not you don't try to resolve that in the chart. You need to resolve that face to face.
You can put factual things in the chart, like you know, when you called a consultant and when they called you back. I mean, if it's a fact that you've been calling them for 2 hours, that can be in there. But just be careful how you word it. If you and another provider disagree on a plan of treatment, you can, you know, put the content of the discussion in there. But there's ways to do it that states the facts without being inflammatory.
Right. Because I can guarantee you, if the patient sees their record, you can bet the consultant or the other physician will see it.
Right, but I mean, having facts in there, you know, like I've had, you know, don't say I didn't call back for 3 hours. It's like, well, I'm sorry,
but you didn't.
You know, you know, it doesn't matter what the reason is, but you know, if there was a delay in treatment because you couldn't get a hold of a consultant, explaining that delay is
right.
important.
Right. Other things, try not to leave loose ends. If you document something in the HPI or PE, then you've got to address it in the remainder of your chart. So somebody comes in with a complaint, say sore throat, and then during the history you find they describe, oh yeah, I've had shortness of breath and this weird rash. If you don't really think that's germane to their complaint, I would not put it in. If you think it's germane, then obviously you should include it. But if it's not, don't put it in. Because, if, like I said, if you raise it in the HPI, you're going to have to do an exam to evaluate it, and you may even have to order some tests to evaluate it. And if you don't think it's germane, then I would encourage you to just stay out of that issue.
Right.
I think our scribes get really, really good as they get experience of identifying, you know, what's germane and what's not.
The patient is here for abdominal pain. I'm not really concerned about, you know, the headaches they had a week ago or the you know, blurred vision they had yesterday or whatever, because you know, while it may be, if you're a primary care provider and you're doing a full H&P and you're addressing all their different issues, if they're in the emergency department for an emergent condition, the chart really needs to reflect that. Now, by the same token, you don't want to have such tunnel vision that when your initial opinion of a patient isn't working out, that you don't go back and think about some of the things they told you, because at some point maybe it was germane and you just didn't think it was.
If they have headache and during the HPI they mentioned dizziness and neck pain, well, that's probably important to know.
It could be. So, you know, fever and
yeah, exactly. So but try not to leave loose ends. Obviously, if you order a test, you want to follow up on the test result. Certainly there are some times when the test won't be back before you have completed your evaluation of the patient, and in those cases make sure that you identify how that test result is going to be followed up. I would give you a special word of warning in this also. In this day and age, a lot of emergency departments are using preemptive labs, and oftentimes those will be put in under a physician's name, and you may not even know that at triage they ordered a D-dimer. And so just be careful. Make sure that when you are evaluating a patient, look at what's been ordered and make sure that you follow up on it.
That's a really good comment, because in fact, this happened to me just the other day where I was discharging a patient, and somehow I looked on results and there was a urine, which I never ordered, but it showed a UTI, which the patient wasn't complaining of. But then I'd already discharged the patient. I had to go run and catch him and go, oh, by the way, that urine, stop, hang on a second. You know, then we had to address it. But you know, so I usually kind of make a habit of at least looking at the orders on a patient or the results on a patient before I hit that final discharge, to make sure that somebody didn't do something that I didn't know about.
Absolutely. So to wrap up, avoid inconsistencies in your chart at all costs. Always assume the patient, the family, their lawyer, or whoever will read your chart and not be happy with it. So avoid pejorative comments and chart wars, because like I said, you never know who's going to see the chart. And try not to leave loose ends. That's pretty much everything for this time. Our next module is going to be documenting the turnover. We all know that turnover is a high-risk area in emergency medicine, and we have some tips and tricks to help lower that risk a little bit for you and hopefully help provide better care for your patients. So till then, as always, if you guys have comments or questions, please drop us a line, and we'll see you next time.